today I'll be presenting on leveraging big data in sleep medicine in my work to predict the development of atrial fibrillation, and also some background work which predicts the development of other cardiovascular comorbidities. I have no financial disclosures. These are our objectives today. First, you'll be able to identify challenges in defining sleep apnea. Second, you'll be able to list approaches for addressing the heterogeneity of sleep apnea. And third, you'll be able to analyze various methods for evaluating hypoxia as a risk factor for atrial fibrillation. So we'll start with some background. As this group knows, OSA is a common nocturnal stressor that is vastly underdiagnosed. 80 to 85% of cases are estimated to be undiagnosed. OSA is associated with increased mortality, as you can see by the graph on the right here, and increasing AHI is associated with worse survival probability. So we won't spend too much time on this fact. OSA is associated with a fourfold increased risk of atrial fibrillation, which I'll abbreviate as AF. Just like 80 to 85% of patients are estimated to be undiagnosed, 85% of AF patients are estimated to have unrecognized OSA. AF is an arrhythmia that is irregularly irregular, as you can see in the image on the right here, meaning that the rate is irregular with no pattern to it, and there are no P waves which would represent atrial depolarization. AF affects 3 to 6 million people here just in the US alone and 50 million people worldwide, and the prevalence is rapidly increasing, as you can see by the graph on the left. It's estimated that by 2030, 12 million people in the US will be affected by AF. AF is particularly important because it increases the risk of cardioembolic stroke or ischemic stroke by 5-fold, which is one of the biggest causes of disability in the world. Prevention efforts are very important, and sleep disorders can be a potential preventive target. So there are several mechanisms by which OSA and AF are related, and we could spend a whole hour talking just about this. So I'll try to be a little bit brief talking about this part, but the relationship may actually be bidirectional, but the prevailing thought is that OSA causes AF. So there are acute mechanisms by which this occurs, such as intermittent hypoxia and hypercapnia, which occur with respiratory events that lead to oxidative stress at the cellular level and autonomic fluctuations systemically. There's increased vagal tone during the respiratory event, which shortens the atrial effective refractory period, followed by a sympathetic surge after the event when airway patency is restored. The increased sympathetic tone has been shown to persist in wakefulness as well, which may also contribute to AF risk. Acutely, there's also intrathoracic pressure alterations that lead to atrial stretch and cardiac substrate changes such as fibrosis over time. Fibrotic substrate has altered connexin proteins, which leads to intercellular conduction delays, and calcium calmodulin-dependent protein kinase 2 phosphorylation, which also leads to dysregulated intercellular signaling. And both of these cellular changes lead to increased AF risk. And then there's other subacute and chronic changes of OSA, which may increase AF, such as systemic inflammation and pulmonary hypertension. So these are just some mechanisms in the pathway between OSA and AF. So it's challenging to define sleep apnea because what we use clinically for both diagnosis and severity is the apnea-hypopnea index, which does not tell the whole story and doesn't tell us much about all of those mechanisms I just mentioned on the previous slide. So here's an example comparing the AHI with the oxygen desaturation index, or the ODI, and the time with oxygen saturation less than 90, or the T90. The AHI in each of these hypnograms is 45, but the ODI and the T90 are vastly different. In the leftmost hypnogram, the T90 is 0, in the middle it's 9, and on the right it's 77 minutes. Here the T90 they're describing in minutes as opposed, sometimes it's in percentage, here it's in minutes. So hypoxia may play a much bigger role in the mechanism between OSA and AF than the frequency of events or just the AHI. But each of these sleep studies would be distilled to just an AHI of 45 clinically. This is a depiction of how the genotype or genetic makeup of a person contributes to their endotype, which presents as a clinical phenotype and then which responds to a certain treatment. In other words, knowledge of an underlying endotype can impact treatment response. So the top panel describes a known pathway in diabetes to give just an example of how this works. But more importantly for us, the bottom panel describes some OSA pathways suggesting we consider underlying endotypes when considering treatment options. And it also implies that we consider treatments other than CPAP. For example, the low arousal threshold endotype shows up as the disturbed sleep phenotype and may respond to sedative hypnotics. Another example is the high loop gain endotype shows up as the OSA with cardiovascular disease phenotype and may respond to CPAP or acetazolamide. And the moderate loop gain and moderate arousal threshold endotype shows up as the minimally symptomatic phenotype and may not need any treatment. So these phenotypes have been identified with cluster analyses that I'll briefly introduce on the next few slides. Cluster analysis is one of three ways that I'm going to describe to address the heterogeneity of sleep apnea. So Andrei Zinchuk and colleagues at Yale identified 6 phenotypes: classic OSA, oldest comorbid, female insomnia, youngest upper airway symptoms, severe hypoxic, and severe non-hypoxic. And they found that these phenotypes were able to predict prevalent and incident cardiovascular disease and CPAP adherence, suggesting that treatment could actually be tailored to subtype. And they were one of the first to do this as well. I know there's a lot of information on this slide, but it kind of is just showing you that they were able to take a large data set and distill it to these 6 subtypes, and then they were able to predict outcomes based on these subtypes. The same group identified a new group of phenotypes: mild periodic limb movements of sleep, non-REM and poor sleep, REM and hypoxia, hypopnea and hypoxia, arousal and poor sleep, and combined severe. And they found these 7 subtypes to predict acute coronary syndrome, transient ischemic attack, stroke, and mortality. And you can see in the graph here that the periodic limb movements of sleep and arousal and poor sleep phenotypes had the lowest probability of avoiding an event. So these were the worst phenotypes to have. Mazzotti and colleagues at the University of Kansas identified 4 phenotypes of OSA patients in the Sleep Heart Health study: disturbed sleep, minimally symptomatic, excessively sleepy, and moderately sleepy. And these were based on a list of symptoms describing sleepiness and insomnia symptoms. So this was interesting because it was all symptom-based. And these phenotypes were able to predict incident cardiovascular outcomes. You can see in the graphs here that the excessively sleepy phenotype had decreased survival probability with incident cardiovascular disease, heart failure, and coronary artery disease. So this suggests, this and the other studies as well suggest that OSA symptom subtypes represent clinically relevant underlying disease characteristics. Lee and colleagues were one of the first. You can see this study is from 2014. The other ones were from 2018 and 2019. They were one of the first to identify OSA phenotypes, and they identified these 3: disturbed sleep, minimally symptomatic, and excessive daytime sleepiness. So you can see there's been some overlap across these different groups. Endophenotyping is a second approach to better understand the heterogeneity of OSA. Sands and colleagues at Harvard have been leading the charge on this. They've described 4 primary components to one's endotype. There's upper airway collapse or anatomical compromise, which is, it's been described as the anatomic prerequisite to OSA. And then there's the 3 non-anatomic components. There's arousal threshold, pharyngeal muscle responsiveness, and loop gain. OSA is associated with low arousal threshold or a predisposition to awakening due to respiratory events. Poor pharyngeal muscle responsiveness or impaired dilation of the pharynx in response to airway collapse, and high loop gain or instability of the ventilatory control center. So there are different combinations of these 4 components that can describe one's endotype, and people with the same AHI but different endotypes may respond best to different treatments or be at risk for different outcomes. Novel metrics are a third and final approach I'm going to use to describe to better understand the heterogeneity of OSA. Ali Azarbarzan and colleagues at Harvard described the sleep apnea-specific hypoxic burden, which is a measure of the area under the oximetry curve. The duration, or X, is the subject-specific search window. All of the curves for a given person's night of sleep are overlaid, as you can see in panel B on the left here, to determine the duration. They're lined up by the end of the respiratory event. And then the depth, or Y, is measured from the baseline to the nadir saturation. The baseline is considered to be the maximum oxygen saturation in the 100 seconds prior to the end of the respiratory event. And then each individual desaturation event is added up, and the total is divided by the sleep duration. And since you're only looking at those desaturation events associated with respiratory events, it also incorporates AHI, or frequency of events. Hypoxic burden has been shown to be associated with cardiovascular disease-specific mortality and all-cause mortality in the Mr. Oz and the Sleep Heart Health Study cohorts. You can see here there is a nearly monotonic, not quite monotonic, relationship between hypoxic burden and survival probability, with worse hypoxic burden being associated with worse mortality. Pulse rate response is another novel metric, which also uses the oximetry signal. However, this one uses oximetry-based heart rate. This one looks at the change from nadir to maximum following a respiratory event. What we're looking at here are two different PSG strips. I tried to separate them with the red boxes here. The upper one has a low response, and the lower one has a higher response. But both have an increase in the heart rate following a respiratory event. And what this is getting at is the sympathetic surge that occurs when airway patency is restored after a respiratory event. So trying to get at the autonomic fluctuations in the mechanism of OSA and cardiovascular outcomes. They looked at the pulse rate response, what it looked like in the MESA cohort, and found that it was U-shaped with 3 cardiovascular risk scores: the B-type natriuretic peptide, the Agatston calcium score, and the Framingham cardiovascular disease risk calculation. And then they also looked at outcomes in the Sleep Heart Health Study cohort. And they found that both low and high pulse rate response were associated with non-fatal cardiovascular disease mortality, and all-cause mortality. High pulse rate response was particularly associated with these outcomes, identified by the red line in these survival curves. So this brings me to our work that we've been up to at the Cleveland Clinic that I'll start describing now. We have a large sleep study registry called the STARLET Registry, which stands for Sleep Signals, Testing, and Reports Linked to Patient Traits, which houses over 300,000 sleep studies on over 180,000 patients. It has been collected using natural language processing and SQL methods from sleep study reports and visit and procedure notes from the electronic medical record. We have data on sleep studies, echoes, spirometry, and plethysmography, comorbidities via diagnosis coding, mortality data, and more that I don't have listed here. The graph here shows how many sleep studies we perform per year and what types, to give you an idea of how we're able to collect so much data. The cohorts I'm going to show you on the different studies going forward will differ slightly, but this is a good representation. There's about 71% PSGs, 25% split studies, and 4% HSATs. Because we're looking at 5% or a 5-year incident outcome in some of the studies, we limited the studies to those performed between approximately 2000 and approximately 2015. I say approximately because the years changed in some of the studies we'll look at. We excluded patients whose studies had less than 3 hours of recording time. And about 7% of our cohort had baseline AF at the time of their sleep study, so we excluded those. And of those without prevalent AF, about 50% were lost to 50 patients were lost to follow-up, less than 1%. So we excluded those patients as well. The average length of follow-up was about 7.5 years, plus or minus 3.5 years. This table shows descriptive statistics of the full analytic sample and those with AF. Our cohort had a mean age of 52, was 52% male, 75% white, and had a median BMI of 33. As anticipated, patients with AF were older, more likely to be male, and more likely to be white. They were also more likely to be on antiarrhythmic medications and had a higher prevalence of all the comorbidities that we considered. We first looked at whether OSA was associated with AF in our cohort by simply the AHI. This model and all the following models were adjusted for age, sex, race, BMI, hypertension, diabetes, hyperlipidemia, coronary artery disease, heart failure, myocardial infarction, coronary artery bypass grafting, COPD, tobacco use, antiarrhythmic medication use, and PAP therapy, which was included as a time-varying covariate, meaning if a patient had their sleep study and some time passed before they were put on CPAP, we accounted for that time. And you can see these variables are listed across the bottom of the slide, and I'm going to include them on the following slides to remind you as we go forward. And then we found that for every 10-unit increase in AHI, the risk of incident AFib increased by 2%. And while this was a significant finding, this was right on the border of significance because the confidence interval, as you can see here, included 1. So going back to one of our central themes, sleep apnea is about more than just the AHI. So we were happy to have found a significant result, but we didn't want to just stop there. Randomized controlled trials in our field have not been able to show that treatment with CPAP reduces cardiovascular risk and improves mortality. And a major limitation of these has been that they have risk stratified based on the AHI. So we decided to turn to hypoxia since it has more biologic plausibility. We thought that perhaps those with highest AHI are not those at greatest risk. So our approach to investigating the association between hypoxia and AF started with evaluating the association as robustly as possible, and I'll show you what I mean by this in the next few slides. So we looked at 3 separate measures of hypoxia. We looked at T90, or the percentage of sleep time with oxygen saturation below 90%, minimum oxygen saturation, and mean oxygen saturation. And we concluded that all 3 measures were associated with an increased risk of incident AF, and all 3 were to a greater magnitude than AHI was alone. So we already had internal consistency across these 3 measures. So for, these were all per a 10-unit increase, or a 10-unit, T90 was per a 10-unit increase, and minimum and mean oxygen saturation were per a 10-unit decrease. But they were per 10-unit increment change. We then identified that there was a limitation in our data set. Well, not in our data set, but there was a limitation in how we were looking at hypoxia, kind of in the field in general. Patients with OSA are typically obese, and the median AHI, or median BMI in our data set was 33. So perhaps what we were seeing was a restrictive pulmonary physiology due to obesity and not truly sleep apnea related hypoxia. So maybe what we were seeing was that patients, when they lay flat at night, were becoming hypoxic for different reasons other than sleep apnea related hypoxia. So we wanted to account for pulmonary physiology. And so we decided to adjust for spirometry related measures. So we collected collected spirometry measures, meaning like scraped the EMR for spirometry and found how many patients had spirometry measures. So we were able to find that about 10,000 patients had spirometry, and this was within about a year of their sleep study. So when adjusted for spirometry, T90 remains significantly associated with incident AF, adjusted for any of the 3 spirometry measures we adjusted for, which were FEV1, FVC, and the FEV1 FVC ratio. Minimum and mean oxygen saturation were similar, but on the other hand, AHI was no longer significant when adjusted for any spirometry measure. So we were able to show both internal consistency across three oximetry measures to a greater magnitude than AHI and robustness to adjustment for spirometry that did not hold up for AHI. So therefore, this suggested that sleep-related hypoxia is associated with AF independent of pulmonary mechanics. And then we have to just mention there's the limitation here of potential type 1 error because of the decrease in sample size. We went from 42,000 to about 10,000. So it could be that AHI lost significance because we were greatly decreasing our sample size. That could be possible as well. So our second approach was to do a cluster analysis. As discussed in the earlier section, cluster analysis or patient phenotyping considers heterogeneity of a diagnosis. So this slide summarizes the phenotypes identified in some of the prior studies that we talked about, as well as others that we didn't discuss, such as the upper airway phenotype. And phenotypes have been found to differ in CPAP effectiveness, quality of life, cardiovascular disease, and mortality, showing strong clinical relevance. However, no cluster analyses have focused specifically on AF until ours. So this is a similar cohort to the one already presented, so I won't spend too much time describing it. But one difference is that we excluded home sleep apnea tests because we wanted to include sleep architecture measures, and we excluded those with missing AHI data. We had about 43,000 patients in our cluster analysis and about 40,000 patients in our outcome model, and about 9,000 patients in our outcome model developed incident atrial fibrillation. This data was just accepted for publication on Friday, by the way. So I don't have the citation on the slide just yet. So these are all the variables that we use to identify the clusters. You can see that there are a lot on here. This is because we used latent class analysis. This is a method that works by inputting a lot of variables into the model, and then you remove them one by one until you have a smaller set of variables that best differentiates the clusters that are clinically relevant. So you start with many and you end with just a few, and I'll show you the few that we ended with in a moment. But I just wanted to show you kind of everything that was input into the model at first. So we included many symptoms, and the percentages here are how many patients endorsed the symptom. And we also included all of these data from our PSG reports. We included the Epworth score, we included the AHI, we included number of hypopneas, number of central apneas, obstructive apneas, and mixed apneas. We included CO2 data, we included percentage of each sleep stage, PLM data, sleep latency and REM latency, sleep efficiency, wake after sleep onset, arousal index. So we included a lot of data here. So this was a two-step process. The first step was the latent class analysis or the cluster analysis where the clusters were identified. And the second step was the outcome model where a member of a specific or being a member of a specific class or a specific cluster was looked at as a risk factor for AF. And the covariates here were the same as the ones I listed earlier: age, sex, race, BMI, tobacco use, cardiopulmonary comorbidities, antiarrhythmic medications, and positive airway pressure. So these are the clusters that we identified. We called them long sleep and REM, hypopneas, short sleep and non-REM, apneas and arousals, and hypoxia. The variables that ended up in the latent class analysis were presence of witnessed apneas, Epworth Sleepiness Scale score, apnea-hypopnea index, number of hypopneas, total sleep time, T90, REM latency, REM percentage, and arousal index. And the graph here shows the standardized means of each variable by cluster. So a higher value here indicates a worse value of the given variable. So you can see that long sleep and REM has the lowest values of almost all the variables, so the best values of each variable. So this was used as our reference cluster because it was the best cluster. Hypopnea stands out as having the highest number of hypopneas. Short sleep and non-REM stands out as having the shortest total sleep time, longest REM latency, and lowest REM percentage. Apneas and arousal stands out as having the highest AHI and highest arousal index. And hypoxia stands out as having the highest T90. And we were also able to see all the other variables that were input into the latent class analysis. We were able to see those values, even though they weren't used to differentiate the clusters. And we also found that for hypoxia, hypoxia had the highest Epworth Sleepiness Scale score. They were all very close, as you can see here. But hypoxia had the highest score, and they also had the highest average heart rate during the sleep study. This is just the major thing to show here is the pie chart describing the clusters by size. And you can see that the reference cluster, long sleep and REM, the red here, was the largest cluster by far. So most patients fell into the reference cluster or the best cluster. This is the result of the outcome model. So the hypoxia cluster, or the purple line on the graph, was the highest risk of incident AF at 48% increased risk compared to reference. Apneas and arousals had 22% increased risk from reference, and short sleep and non-REM had 11% increased risk from reference. And the hypopneas cluster did not differ. In conclusion, we were able to identify 5 clusters within our large data set, and we found that, consistent with our previous work, hypoxia is a driver of AF risk. The hypoxia phenotype was also the sleepiest, so we showed that the sleepy phenotype carries cardiac risk. And next steps here are to see if these clusters exist and these conclusions hold up in other data sets. And yeah. So the third way we are evaluating hypoxia as a risk factor for AF is by employing novel metrics. So this is still new work, so I don't have too much to show yet, but again, we're looking at a measure incorporating the depth and duration of sleep apnea-related desaturations. We're also looking at pulse rate response, but instead of using the oximetry signal like they've done in the literature, we're using the ECG signal. They've used the oximetry signal in the literature because they wanted to be able to look at HSATs and PSGs, but because we have such large numbers, we're able to look at a large number of PSGs alone, so we're looking at ECG signal. We're leveraging a collaboration with our new sleep center data scientist, Dr. Araujo, and our IBM collaboration to do this work. So you can see here in this image, you can see the patient-specific search window. You can see the pulse rate response to the respiratory event by the red. Can you see my cursor? No, I don't think you can. Laser pointer? Okay, perfect. So you can see the apnea here. You can see the patient-specific search window here, and this is the sleep apnea-related desaturation. So this triangle here is the hypoxic burden area under the desaturation curve, and this response here is the pulse rate response. So these two, this area under the desaturation curve and this pulse rate response are the two novel metrics that we're computing in response to each apnea, or each respiratory event, I should say. So for completeness, I also wanted to discuss our work in the sleep architecture realm as well, starting with some background. So what we know about the relationship between sleep architecture and AF is a bit limited because the studies that have been done have shown inconsistent results. Epidemiologic studies lean more towards arousal index being protective against AF. And the basis of this theory is that in OSA, the arousal often truncates the respiratory event. So a higher arousal index may be indicative of shorter respiratory events, which may cause OSA to be less of a stressor on the cardiovascular system and cause less hypoxia. So studies have shown a negative association with prevalent AF and a weak association with prevalent cardiovascular disease as well. So data from the sleep heart health study actually showed that a low arousal threshold predicted mortality, which was a little bit different. On the other hand, several mechanistic studies have shown that arousals are indicative of sympathetic surges, which would intuitively increase cardiovascular stress. So this line of investigation between arousals and AF has been pretty inconsistent, and studies of longitudinal AF are lacking. As far as total sleep time and sleep duration, a study in 2019 showed that short sleep is associated with AF, but another study showed that short sleep is not associated with CVD and all-cause mortality. But another study showed that short sleep was not associated with AF. Again, basically this is just very inconsistent. And there's not a lot of longitudinal studies here. A lot of these are cross-sectional. So this lack of clarity and lack of consistency in the literature created a persistent knowledge gap that called for a high-powered longitudinal study with a large data set. So that's what we were powered for, and that's what we attempted to do. So we found that for every hour of lost sleep time, the risk of AF increased by 5%. For every 10 percentage point decrease in sleep efficiency, the risk of AF increased by 5%. And for every hour increased wake after sleep onset, the risk of incident AF increased by 9%. Our primary predictor was arousal index. We didn't find any association between that and AF actually. And we didn't find any association between any sleep stage characteristics and AF. And this manuscript is under preparation now. The way that we examined arousal index was categorically in quartiles and continuously, and we weren't able to find any significant correlations there. So that's all I have. I would like to thank everyone listed on this slide and probably more people that I don't have on here, as well as all of the funding listed here. And I thank you all for your time this morning.